now. So I'm going to now entertain you, or try to entertain you, on the benefits and safety of HRT. Those of you who are quite observant about this will know that I have spoken about this before, and some of the slides will be familiar to you from my last year's lecture. But what I've tried to do is to put in as much new thinking as possible. Obviously, I've used the key slides from the last talk, but I've also found some evidence that has become available thanks to me just going to lots of conferences, to the British Menopause Society, but most importantly, 3 weeks ago in Valencia to EMAS. So a lot of the material will come from that work. So we're going to be thinking about two areas that are not well covered in the current guidelines. First, and certainly something that I didn't really talk about at all in my previous lecture, starting in perimenopause as a routine, starting the moment a woman's symptoms manifest, and also the very, very long-term use, because you may remember that I suggested that you should be using it for the rest of your life, and it looks as if from some very large studies now coming in from the States that there is unquestionably a benefit to very long-term use. So once again, the two sources actually, not just EMAS and the BMS, British Menopause Society. There's also a film that I watched, and I helped with a presentation, question and answer in Paris 2 days ago. This is called The M Factor. It's an American television film. If you get a chance to watch it, it's very well done. There's a few technical mistakes in it, but mostly it's absolutely on the button, because the use of HRT in America is apparently only about 1.8% of women. It's lower now than it's ever been. And think of the morbidity and indeed mortality that low, desperately low use of estrogen is causing. I mean, in Britain, for instance, the current usage is something like 15 to 16%. Now, that is the highest in Europe. It's probably the highest anywhere in the world, and we are trying to get it up to at least 30%, maybe even 50%. Certainly to all the women who have symptoms, and maybe to consider it for primary prevention under certain circumstances. So we're very keen to fly the flag for estrogen therapy, but the question's got to be, what are the benefits, and is it safe? And that's what this lecture is going to be about. Another thing, of course, is if we're starting, when should we start hormone therapy? And I'm going to call it hormone therapy. And I tried to do this. I wanted to do an HRT lecture without ever mentioning the Women's Health Initiative in the States, but it's difficult, very difficult to avoid mentioning the WHI. So I thought I'd better start with my classic WHI slide, and this is the press announcement of the original results, not by the principal investigators, remember, but by the administrative writing team, who never told the principal investigators that they were going to produce the paper and also publish it in the New York Times before they published it in the Journal of the American Medical Association. And actually, so if you talk to some of the principal investigators, they were absolutely livid, and they said, this is a disaster, you've got it completely wrong. The principal investigators knew at the time that this was published that the analysis was false. But the administrators wanted to create a splash. And what they said was, amongst many other things, that HRT increases the risk for breast cancer and for blood clots. Now, we know that the WHI is the primary source for misinformation about HRT. So let's just look at this statement and see if they had actually got it right. This study might have been helpful. If this man instead, this imbecile, I'm sorry, I can't think of anything polite to say about this gentleman, actually. Not just him, but of course the whole team that worked with him. Not the principal investigators, obviously. But this group of writers, group of administrators, has caused more damage to women's health than almost any other single event. Perhaps, unless if you consider what Trump is doing to Roe v. Wade, and watch how Chesky did in Romania. That's a bit of a disaster. But let's see how could we amend this statement to make it correct. So let's have a look. If he'd said that synthetic oral HRT increases the risk for breast cancer and blood clots in older, iller, overweight women. Remember, that's most American women. Sorry, not too many American women around here. We can say that between us, can't we? Then actually that's a correct statement. Because what WHI showed is that you shouldn't give artificial HRT, conjugated equine estrogen and hydroxyprogesterone acetate, the worst possible progestogen you could give, the one with the poorest metabolic profile, highest risk of type 2 diabetes and a whole load of other complications. You certainly shouldn't give it to a bunch of women who are on a mean age of 62. Their oldest patient was 79. I mean, nobody, how could that have been indicated to give suddenly start a 79-year-old on full dose oral HRT? Absolutely unconscionable. Anyway, these women, once again, they were too ill, too old, too fat, wrong drug, bad science, bad press. That's it in a nutshell. But that statement is now correct. And that's what we should have learned from WHI. And so what does that mean? What does that tell us now? What can we glean from the disaster of WHI? We don't give synthetics. Almost nobody does nowadays. Certainly nobody gives conjugated equine estrogen in Europe. Not many people that I know. We don't give oral, particularly to overweight women. Some people still use oral, but mostly we've moved away from using oral and we're using transdermal for just about everything. Also, if you have an older woman, you don't want to start HRT in an older woman unless they suddenly realise that they ought to have had the treatment a long time ago and they would like to start, in which case you must start with transdermals and probably at low dose, and they do not come to harm. Actually, one of the other things that WHI showed is that if you treat women over 60, they do not have an excess risk of heart disease when all the reanalysis was done. So this is important to know. So what does it mean then? We're going to use human estrogen and progesterone and treat transdermally. And when are we going to start? We're going to start young, not old. That's the lesson from WHI, apart from all the rest of the rubbish. Now this particular graphic is produced by Lisa Mosconi, who's done an enormous amount of excellent work on the neurodevelopment and the neurological consequences of HRT and also of estrogen loss and lack. And what they looked at was particularly cognitive decline, because I think cognitive decline, brain fog, if you like, is the most important initial event, not the hot flushes, which everybody talks about, the hot flashes as they call them in the States, but cognitive decline is probably the most debilitating of all the various different symptoms, and they're all linked. Of course, cognitive decline is linked to mood and anxiety and insomnia. Now, if you put all that lot together, most women faced with cognitive decline, particularly if they're in an executive function position, a nurse or a doctor, will have poor performance at work. They will be incapable, not totally capable, but it will be very difficult for them to do their jobs. For instance, to give you an example, what about the condition dyscalculia? Inability to add up, subtract, etc., do simple mathematics. Now, if you're an accountant, you wouldn't be able to do your job. But just imagine if you were a consultant anaesthetist and you got dyscalculia, that could be fatal for your patient. So, I mean, I had several professional colleagues who say that they're taking much longer to write their reports, such as radiographers or radiologists, and many of these get unfairly dismissed from work because they're unable to perform. Now, it's quite normal if you put all that lot together that they're going to have low libido because they're stressed out, they can't sleep, etc. Low libido is a natural consequence of all these different problems put together. If you then add those up, any woman faced with cognitive decline, mood anxiety and insomnia and low libido is going to be reactively depressed, not endogenously depressed, but reactively depressed. It is normal to be depressed when confronted with all these various different conditions. If they find, if their GP diagnoses that they are depressed, what's going to happen to them? The most likely thing is they're going to be given antidepressants, which is the worst possible thing you could do to a woman who has hormonal cause for her low mood and her depression. Also, another thing that you need to know, I think this is very reasonably commonly known, is that the maximal suicide risk occurs in the UK statistics between the ages of 45 to 49 and 50 to 54. Those two age groups have the maximum suicide risk, and it's very highly significantly different from the ages outside that time, and you don't have to be a genius looking at this graph to see why that is. So one of the things you're trying to prevent with HRT, timely given HRT in the perimenopause, is suicide. And somebody commented quite recently is that it doesn't matter how much of a risk for breast cancer HRT is. If it's going to stop a woman attempting suicide, then I think the mortality from suicide is much higher than any potentially slightly increased incidence of breast cancer. And I think you have to try and get things in proportion here. What's important for the woman's future life? Also, of course, if you think of not only what it causes the suicide risk, but the low libido and depression, even worse if they're given antidepressants and it causes anorgasmia, etc., then that's the point at which relationship breakdown kicks in. And so basically when you start, you don't wait until postmenopause, you don't wait until they're right at the very lowest point, although of course some of them will only come and see you at the very, very lowest point. Unfortunately in some cases it may be too late, they might already have killed themselves. Start when their symptoms start, and then you will achieve some sort of a benefit. It would be nice to think that you could, for God's sake, give hormones and not antidepressants. So that's just from one particular graph that was actually on the M Factor film. I could not find the actual reference, and I'm actually going to write to Lisa Mosconi to try and find the reference for that, but it's actually very important. So, where do we go from there? Oh yes, I've said that you could start hormone therapy to treat perimenopausal depression. Now, one of the things that we've been doing is trying to find new evidence. And one of the problems about new evidence is that some of the evidence is there from years ago, and it was just never properly dug up. So this is actually a randomized controlled trial done by psychiatrists, published in 2001. And remember, any of this material would have been swallowed up, if you like, by the panic about WHI. So this is a 17 beta estradiol patch for 12 weeks versus placebo in 50 women aged 40 to 55 years. And it's done by the person that, if you only read one reference from the whole of this conference, then this is the man to read. Claudio Soares is Professor of Psychiatry in Ontario at Kingston University, and he is quite excellent. The psychiatrist who I met at the ESC in Budapest about 10 years ago, and he says, I'm a psychiatrist and I haven't used an SSRI in any woman for 10 years. And that was 10 years ago, so he's been on board for a long time. He did his PhD on this subject. So here's the results. They had 26 women with major depressive disorder, 11 with dysthymic, 11 had minor depressive disorder, and they got a remission of depression, 20% placebo effect, and a 68% estrogen effect. So could you do better than that? Well, maybe you could use the treatment for longer, and this is a trial from the States from Dr. Gordon's unit, and she's actually now the head of the IAPMD, the International Association for Premenstrual Disorders, and as one of the lead researchers here. And what they found was that there was using the this is actually women who were not depressed. They took women who were not depressed, but who were starting perimenopause, and then gave them 12 months worth of estrogen patches and treated them every 3 months with medroxyl for those who had a uterus, treated them for 12 days every 3 months to get the bleed. 172 women, and they found this very significant difference here. So about half of the width of the sort of was the double effect, if you like, from the transdermal estrogen. So, why start it? Well, that's the obvious answer, is that the women who are in perimenopause are subject to the winds of fate, and you've seen this graphic before. This is perimenopausal vulnerability. They're subject to the winds of fate, and you could give them a protective blanket. Now, that would be nice, but maybe you're not going to give it for various different reasons. Maybe you don't believe in giving HRT at all, or certainly not giving it until they're actually post-menopausal. So let's look at the various different societal problems, the winds of fate, if you like, that blow on perimenopausal women nowadays. Well, there are lots of them. Some of them doctors can help with, and others they can't. Sexual violence, pornography, relationship breakdown, dating apps, social change, etc., etc., etc. And the men have got something to help themselves with the erectile dysfunction treatment. But what these women are getting is inappropriate treatment with SSRIs as the first line from most family doctors, and they've got misinformation about HRT. So what that actually produces is the wrong treatment and no HRT. So they lose their protective blanket for all these various different systems that could benefit from having HRT, particularly the cognitive function, various different brain functions, and also genital health as well. So if you have no HRT, you get genital problems, and that will cause, you'll get genital urinary symptoms of menopause, and that causes poor lubrication, fragility, and dyspareunia, etc., etc. And if you have no HRT, you remember this graphic from last time, this lack of joy. It's not just lack of joy, it's depression, it's low libido, it's a whole load of other problems as well, it's poor sleep. And faced with that situation, it is absolutely normal to suggest that this is going to lead to relationship breakdown. And if you put that together with if their relationships break down, then they may go back into the sexual marketplace. And what are they going to do? How are they going to find new partners? Well, they might use dating apps. They probably won't use contraception or condoms because they've got to a certain age. They'll have vaginal fragility. So right at the bottom, they're going to get more genital problems and lots more sexually transmitted infections in the older age group. And that's why we're here, isn't it? Because this is IUSTI EE, and that's where the STI comes in here, although I won't be talking about it from now on, but that's where it happens. So we need to watch out for it. Okay, so let's think of the benefits and safety of transdermal human HRT. The bottom line is that there is a 1/3 reduction in all-cause mortality. Now, I put it to you that in any other field of medicine, if you had a pill, a tablet, a treatment for that could actually reduce mortality in your population by 1/3, why would you not give it? You'd be an idiot not to give it, wouldn't you? An absolute idiot. So let's look at the various different systems. You know all this. You have less neurodegeneration, better cognition, less insomnia, less exhaustion, better sleep, less anxiety, depression, better mood, which we've already demonstrated in a couple of the papers there. Oh, isn't it nice that you have actually less death from cardiovascular disease, which is the principal contributor to the lower all-cause mortality. It's also rather nice that you have no or minimal excess cancer risk, because I'm talking about only using transdermals and progesterone, or it's stereoisomer dihydrogesterone, or the Mirena levonorgestrel IUS. So those are the only treatments that we're actually using. We're not using any of the other synthetic progestogens, and so that's the situation that certainly for the first 5 years you have no excess risk of breast cancer, and then thereafter it's very, very small indeed. And certainly we know, and I'm going to show you in a moment, less death from breast cancer if you happen to be on HRT at the time you take it. You get less bowel cancer, less type 2 diabetes. Well, I mean, you can go on and on and on. But one of the things that actually is rather nice is for bones. Because for primary prevention, the first indication for primary prevention, as now sanctioned in America, the American guidelines and the Australasian guidelines, now say that you can use estrogen for primary prevention of osteoporosis indeed in the perimenopause if you wish. So that's a very good start. I'm not going to go through that data because it's very complex. But then the question is it really, really safe? And if you still have this in the back of your mind, could it be that safe that it's giving a lower all-cause mortality? It suggests that it is relatively safe. But what's the alternative? And how safe is the alternative to HRT? Well, the problem is the biggest danger with HRT is in not taking it. Because you are then at the mercy of your GP to give you any drug they like for any system in your body that could be causing a problem. They find a drug and give it to you. Well, what about cognition? There are no treatments that improve cognition in women apart from estrogen. Oh, sorry, bottom line, I completely forgot. The bottom line is that you end up with more visits to your GP, it costs a lot more, and you have higher mortality, poorer quality of care, poorer quality of life. That's what happens if you don't take HRT. So, here's the top. Sorry, I've jumped the gun a bit. There are no treatments that improve cognition apart from estrogen and possibly testosterone. If you can't sleep, you'll get hypnotics and sedatives and you'll become addicted. And don't get me started about antidepressants, because there's a 70% anorgasmia risk with SSRIs, and no GP will ever tell their patients about that. Also, with the heart, you need ACE inhibitors, statins, etc. Also, you're more likely to die if you don't take HRT. Oh yes, and as with breast cancer, interestingly, one of the things that estrogen does, it probably promotes a micro breast cancer that's already present. It probably doesn't cause the breast cancer, it just promotes it faster. So women who don't take HRT present with breast cancer later with more aggressive histological grades, which are more likely to have spread, and therefore they have a higher mortality. You have more type 2 diabetes, you need biguanides, the genitals, well, without estrogen in the genitals, then you're really in trouble. You get GSM, and you need more antibiotics, antifungals, antispasmodics, etc. The bones, these are not good treatments. Bisphosphonates are not good treatment for bones. Certainly you can't really use them underneath the age of 65. And once again for veins, you need anticoagulants. So I would say you should stop. Stop all of that. You don't need any of those treatments, any of those very costly, ineffective treatments. Although some of them might be slightly effective for the one system that you're trying to treat, but they don't treat the whole patient. So let's see where to go. Oh yes, just now to remind you from some of the previous slides that you've seen, this is transdermal. Transdermal estrogen is obviously much less damaging in terms of thromboembolism, simply because it doesn't go through the liver. Less than 5% of estrogen taken transdermally is metabolized in the liver, whereas 95% of oral estrogens metabolized to estrone, which is much less effective, and the risk of VTE is the same effectively as no treatment at all, and the risk of VTE with an oral regime is 4 times that of a transdermal. Don't do it. What about cardiac death risk? Well, we now move to our friends in Finland. We just had one excellent Finnish speaker. The person who really takes the biscuit is actually Tommy Mikkola and his group in Tampere, I think. And he's working very hard on producing these lovely statistics from their national medical database. And statistically, you find that if you start the treatment with HRT in the 50s, at the time that you should be starting it, if it's post-menopause, then you get a very substantial reduction. You halve the rate of a death from cardiac disease. Even if you start in women in their 60s, there's an improvement, about a 40% reduction. And this is amazing. Even if you start women in their 70s and 80s, very few women actually start at that point. They seem to have a benefit. Now, that might just be a healthy user effect. Those women who are sufficiently articulate to ask for HRT and get themselves to the doctor might have a cardiac benefit there. But that's actually very important. So what they found was that you get a larger coronary heart disease mortality risk reduction. These occur the earlier you start the therapy. So the sooner you start, the better. So the idea is start early. What about breast? Absolutely amazing. If you're on HRT, you have a 2/3 reduction in death from breast cancer if you're in your 50s. Now, not a lot of people know that, that risk reduction is also there, not quite so impressive, but a 1/3 reduction in your 60s and a 1/4-fold reduction in your 70s. And the bottom line here is that the overall fatality rate is halved if you're taking HRT at the time you're unlucky enough to get a breast cancer. So that's very important. And I put it to you, that's probably too large to be a so-called healthy user effect. Okay, now on to the final thing, effectively, the evidence that you've seen before is brain, and I'm summarising, crunching this up into one or two studies. Remember, the jury is still out on Alzheimer's disease and neurodegeneration. If you take any observational study, any of the retrospective or prospective observational studies seem to show an improvement in brain function and reduction in Alzheimer's disease. But none of the randomized controlled trials have yet shown it, largely because of selection problems with those studies, and also none of them are probably ever going to be long enough to know what the result is. So let's look back with a very large database, nearly 400,000 patients in the database, and look at the different types of estrogen, the effect of estrogen on Alzheimer's, and the effect even of conjugated equine estrogen, a reduction to 0.4 of what was previously occurring, and a reduction of 0.2 for Alzheimer's disease in these insurance-linked databases. This is actually very important stuff. What about another study where they're looking at reduction in Alzheimer's disease, looking at this from a perspective. This is actually a much better trial, and it came out just a few months after WHI. It was completely squashed, and it was an amazing result. And if we just look at the detail in this graph, you can see what happens in the graph. The bottom line here is the males, and we know that women have 2 or 3 times the male risk of Alzheimer's disease. But look at the 2 bottom lines there. If you take HRT for more than 10 years, then your risk of Alzheimer's disease as a woman reduces to the same as an average man. But the less time you take HRT for, then the greater your risk of Alzheimer's disease. So that looks like a dose-response curve, which starts to demonstrate or suggest a genuine effect. So that's what we've got. Nearly done now. This is, if you like, the last bit of evidence I'm going to show you, and it's very recently produced, to 2024. And this is a study of 10 million American women traced through their Medicare records from 2007 to 2020. This is looking at use of estrogen or estrogen progesterone, HRT, over the age of 65. So all this stuff we've been talking about earlier in the younger women with their various different risks. What if you follow the advice that there should be, this is now been in the guidelines, the UK guidelines for 10 years, that there should be no artificial upper limit to the number of years during which you take HRT. So let's see what happens if you do that. So you're keeping on taking HRT over the age of 65. And the bottom line is that your global mortality is reduced by some 19% reduction to 0.81, and this is just for women who are on estrogen only. And if we look at the various different details here, remember this is against women who've either never used HRT or who've stopped HRT before the age of 65. So what we have is that if you use estrogen only, if you have a 21% global mortality reduction if you're on estradiol, and a 13% reduction if you're on conjugated equine estrogen, highly significant. And although this looks good, transdermal seems to be better than oral. That was non-significant with the small number of people who were taking transdermal in the States. They also had reductions in breast cancer, lung cancer, colorectal cancer, and acute myocardial infarction of these different percentage points, all of which were highly statistically significant. So this is actually a very good study indeed for women taking HRT up to and over the age of 65. What about estrogen and progesterone? Not quite so good. In that case, we looked at, they found that there was an increase in breast cancer, which is what you'd expect because most of the progestins that were used were artificial progesterones, and it was difficult to tease out the two, but there were definitely a small group of women who were using transdermal estrogen and micronized progesterone, and they had much less of the problem, much less actual risk, but there was a slight increased risk. But there were reductions in endometrial cancer, ovarian cancer, heart disease, ischemic heart disease, and venous thromboembolism. So all of these are more or less what you would expect. The bottom line here is their quote here. I don't normally like to read quotes, but I'm going to read it because it's the last quote effectively. Risk reductions appear to be greater with low rather than medium or high doses, transdermal rather than oral, which is what we've said right at the start of the presentation, and with estrogen rather than conjugated estrogen. So that's what we'd like to do. So give them a better drug for a longer time and start sooner. So the summary. Remember that in the last talk, I put up this lovely paper that was called HRT Back to the Future from Roger Lober and a number of other people in 2016. And they said that HRT should be considered as part of a general prevention strategy for women at the onset of menopause. And now we're not talking about the onset of the stopping of the periods, we're talking about the onset of the symptoms of the menopausal transition. So this is at the start of perimenopause. And remember, the worst thing you could possibly do is let a woman be if you like, blown to the winds of her GP and this random polypharmacy that they're going to get. And this is good preventative care. So the summary is, use transdermals rather than orals, use human and not synthetic progestogens, and individualise the estrogen dose. Start early, keep going, and for God's sake, don't stop. And that's really about it. So what about the benefits and safety of HRT? You've seen this slide before. It's much as I said before, with much stronger evidence for it now. As much as you need for as long as you live. Thank you very much. I've actually kept time.
Thank you for excellent presentation. Do we have any questions?
Maybe over coffee, I need one.
Okay. If not, then the lunch is waiting for you.